All right, everybody, we're going to get started with our afternoon evening session. I'd like to welcome everyone back. I hope you guys all had a nice break. Either downhill skiing, cross-country skiing, walking, snowshoeing, ice fishing, polar bear swimming, whatever all you like to do. Just a couple of reminders again, please sign in for your CME. If you don't sign in, we can't give you credit. Just like this morning, if you leave early, please sign out. You don't deserve credit if you're not here. So, if you're joining online, make sure that you update your name on the participation list so you can get your credit as well. Just a couple of things at the end of the session. We'll do a quick drawing for another $50 card. They left all the good ones from this morning, so there's really good ones now. So bathrooms, unisex bathrooms just out the door, and we've got men's and women's bathrooms upstairs as well. We appreciate everyone kind of following our COVID protocols. Keeping your masks up when you're not eating or drinking. So thank you again for all the efforts. It's been a huge privilege to be back in person. So we do appreciate all of the effort with that. And if you feel sick, please check yourself out. We're happy to get you guys set up with a COVID test if you start feeling poorly. Our first talk this afternoon is going to be on marijuana clinical applications and updates. This is Dr. Shenoy. He is an internist from Virginia Mason in Seattle, Washington. He received his medical degree from the University of Washington and is board certified in internal medicine. And he specializes in hypertension, diabetes, and we'll be discussing cannabis clinical applications and provide us an update on cannabis use. So give a warm welcome to Dr. Shenoy. Thank you.
Thank you so much. I really appreciate the introduction. And I really appreciate the invitation to come out here and speak with all of you. I have the unenviable task of going the first speaker after lunch. So I'll understand if we're kind of still waking up and shaking off that food coma, which is probably a particularly appropriate topic then to be covering right after lunch with cannabis. And so again, my name is Ananth Shenoy, and I'm, can't hear.
There you go. There's a button on top of it. Hold that, yeah, right there. Sweet. We get keep going. You mind if I? Thank you. You're good to go. Here we go. Oh, sweet. Yep.
Thank you for bringing that up in fact. Appreciate it. I'm an outpatient internist, and I'm also faculty in our internal medicine residency training program with Virginia Mason Franciscan Health. And I'll talk a little bit more about why I think cannabis is important as something for all of us to address. I'll come to that in a moment, but just to get started, I have no financial disclosures, but of course I'm discussing cannabis, which is a Schedule I substance, so obviously not FDA approved. So that's my disclosure for this talk. And so what we're going to talk about today and what I'd like to cover, and I will say my goal here is really to give you information that hopefully is helpful to you when you're taking care of your patients or when they bring up questions. I mean, ultimately for me, that was the reason why I kind of led to my research into this and ultimately developing this talk. I've had a chance to give it a number of different groups in different states. But what we're going to start with is talk a little bit about kind of how the law applies, cover briefly federal law and then state law. And then we'll talk a little bit about the pharmacology of cannabinoids. And I'm not going to get too bogged down in the weeds. Don't worry, we're not going to go like into tons of depth on biochemistry, but I want to give enough that's hopefully helpful and to understand the different effects that cannabinoids can have. Then we're going to really spend kind of the bulk of our time talking about the evidence basis. Like, what do we know? What can cannabinoids be useful for in terms of symptom relief and conditions? And really, what's the quality of the evidence that is out there? And then we'll talk about the adverse effects of cannabis, and in particular, talk about cannabis hyperemesis syndrome. And then talk about when the patient brings up a question to you, what can you say? Like, where are you on firm ground? And then finally, if we have time, I'm going to address synthetic cannabinoids. And this is kind of an area that's continuously evolving. And finally, we'll have time for questions at the end. Also, I'm happy to take questions at any point. So if you want to raise your hand in the middle, I'll happily stop and tackle a question right in the moment if that works. So with that, I'm going to start with two clinical scenarios. And these are both cases that I've seen in my clinic in primary care. So a 55-year-old with painful diabetic neuropathy and also chronic kidney disease secondary to the diabetes. And they're coming in and their question that they bring up, like they say, and it's always someone else told them to bring up this question to me, so I said introduce it. But my daughter suggested that I try a CBD extract under my tongue that might help with my pain. What do you think? I will say I really appreciate that they're willing to come to me as their clinician and bring up this question. The second one, a little more challenging, with a 75-year-old with really bad degenerative joint disease, x-rays just complete loss of joint space, and have pretty substantial pain and are on chronic opiate therapy. And they bring up their spouse was suggesting they try smoking cannabis because that might help their pain. And for this person, every day is painful. Like every moment of life is pain, and anything they can do to reduce it is something they want to know about. And then this one I've added really more for those of us who practice in Idaho. So in Washington, of course, and I'll cover Washington state law, there's recreational and medicinal cannabis. We've had it for years. So the question about legality doesn't come up so much, but it might be one that comes up for your patients if you're seeing here. So I want to ask a couple questions, and the way I'm going to get answers, I just want to see shows of hands for each, just to help me as I go through my talk. So who has had a patient bring up cannabis use? Wonderful. So obviously, it looks like almost all of us, if not all of us. Who has treated patients for complications? Those hands went up really quick. So cannabis, and in particular, who's seen cannabis hyperemesis? So a lot. Okay. Great. And then as far as where you practice, who practices in Idaho? Great. Majority Washington. My colleague in Washington. And then other states, Montana and Canada. And then finally, this one is kind of more of a thumbs up, thumbs down. What is your level of comfort going into this talk about when patients bring up cannabis or you're talking about their kind of side effects that they're coming in with? Like thumbs up, we thumbs middle, we thumbs down. Okay. So what I'm seeing in the front is mostly thumbs middle. Okay, great. So hopefully there'll be a lot of useful information for you there. Now, one of the other things that I'm going to mention that I've included on all my slides, I've included the links to the evidence. And so in particular, there'll be the PubMed IDs for the articles that'll be listed for each appropriate slide. So if you want to go look up the references later, that'll be there. But we're going to start with that introduction to where do we stand in terms of the legal status of cannabinoids. So of course, cannabis from the standpoint of federal law is a Schedule I substance, which means even if there are any therapeutic benefits, the downsides far outweigh any of the positive sides, and right, there's no appropriate therapeutic role for it. However, you may have had patients bring in little bottles of CBD that they got at the grocery store. Like in Washington, you can get this everywhere. And it's CBD, and they can just go get it anywhere. And that's because in 2018, hemp, which particularly is one of the, really it's a purified version of one of the cannabinoids, CBD, that has no THC. And I'll go over what all those mean in a little bit, but is no longer a controlled substance. So basically, you can get CBD that doesn't have any THC in it over the counter. Now, interestingly, I'll cover this in a moment, but Idaho state law is more strict than federal law. Like the standard that Idaho holds is significantly more stringent than federal law. But what this kind of gets to is CBD without THC in a sense is legal. But cannabis, which includes multiple compounds, is not. Now with Idaho State, and I think you all know this, so obviously cannabis is still Schedule I, and then for the CBD, in spite of the THC, in spite of the federal standard, which if it has less than 0.3% by weight of THC, it's then legal over the counter, so to speak. Idaho has said there basically cannot be any THC, so it's a much higher threshold. So it's kind of our basis on the legal side. And I should have said at the beginning, I'm not a lawyer, so I'm going into more fine-tuned process. Now, I do want to briefly cover how things stand in Washington, even though most of you are clinicians in Idaho. And part of that, and I saw a really interesting article in the Seattle Times, which is kind of like our major newspaper, earlier this week, where they were showing the different distributions of cannabis sales in the state of Washington by county. And the counties that have had the most explosive growth of cannabis are the ones that are on the border between Washington and Idaho, which you probably figure out why that's the case. And so as far as where things stand in Washington, we've had access to medicinal cannabis since 1998, so over 20 years now. And I will say briefly, and I'm happy to talk about this more afterwards for any who are interested or curious. Basically, any clinicians, it's very broad, can provide patients with who have any one of a number of approved conditions, basically a medical authorization, which is really an attestation that says, we have talked with this patient, we agree that they have a condition, and we have discussed with them the trade-offs if they were to get cannabis and use it for these conditions. So, and the reason I specify, and I use the wording that way, in Washington, we can't prescribe cannabis. Like even though there's medical cannabis, we don't prescribe it. You don't go to a pharmacy and get it. Our role as clinicians in Washington is simply, if a patient asks, we can agree and say, we've talked to you about this. You are now making an informed decision, which you can go out and make. And that's kind of how we protect ourselves, given that our prescribing license comes from the DEA. But again, I'm happy to go through this more detail if anyone's curious, but I'll just say that for now. Now, the approved conditions in Washington, I think this is just fascinating, particularly when we get to the evidence basis in a little bit. But this is a long list of conditions, and I've highlighted the ones in green that I'll talk about specifically. But notice there's cancer, HIV, multiple sclerosis, epilepsy, other seizure disorders, spasticity. We also have glaucoma. Then we have things like Crohn's disease, we have hepatitis C, chronic renal failure, post-traumatic stress disorder, traumatic brain injury. A number of those conditions have no good quality evidence to support the use of cannabinoids for at all. So I find it fascinating that when Washington voters and this was drawn up, if this was the list of conditions, we decided it would be appropriate to use cannabinoids, which again, many of these we don't have evidence at all. The ones I've highlighted in green are different. These are symptoms: intractable pain and diseases, any disease that leads to anorexia or nausea, vomiting, wasting, appetite loss, seizures, muscle spasms, spasticity that is not relieved by other treatments. So kind of regardless of these other conditions, if you simply have a symptom that falls into one of these categories broadly, we feel like cannabis is a reasonable thing. So basically, under Washington law, if you were to be giving a medical authorization, you're pretty much covered for anything. Like, I don't have many patients who don't have some pain or don't occasionally get nauseous, right? I mean, these are pretty common conditions. So interesting. Now, the recreational use, and I think this is probably helpful to know if you don't already know, because this is where residents in Idaho, why they can go to Washington and procure cannabis. So in 2012, the Washington voters approved recreational cannabis. So basically cannabis for everyone. You don't need a medical attestation. You just have to be over the age of 21, and you are purchasing from licensed retailers, dispensaries. And the growth of cannabis dispensaries has been amazing. This map is now actually a little bit dated, but all these little blue dots and green dots represent dispensaries. And you can't go anywhere in Seattle, you can't go more than a block without seeing a dispensary. Like, they are everywhere. If you want to find cannabis, it is very easy to get. And the tax revenue and the sales overall of cannabinoids is just, it's a graph that just goes straight up each year. And so in 2021, $1.5 billion in sales, of which the state generated approximately $500 million of revenue, which is a lot. And as far as why there's so much and that much sales, it's because the sales tax is quite high on these products. But anyways, booming business, and you can see a lot of these dispensaries are fairly close to. So one of the questions that comes up, particularly more relevant in Washington, but I think is applicable here too. So why even have a medical authorization or attestation? And why would a patient bring it up with their doctor at all if they can simply go to Washington and get it? And there are particular reasons why the medical authorization remains in place in Washington. Mainly, they can get more and they don't have to pay the sales tax. When the sales tax is like 35%, you're saving a lot of money if you don't have to pay that. But the other part, and I think this is the part that's why it's important for us to cover this and to feel comfortable about it. Patients bring this up to us because, right, we're their doctors and they are concerned about their health. They want to make sure that what they are doing is reasonable, it's safe, it might help them, and they're looking for legitimacy. And I have a lot of patients who bring it up for particularly that reason. So hopefully I made the case that this is worth knowing. Although I think the fact that everybody in this room has had experience and have patients that they've treated probably shows that there's a benefit. So we're now going to kind of dive into the pharmacology, talk a little bit about the pharmacokinetics. Again, I will try not to put you to sleep. So just kind of a review of some of the terms. And when we talk about cannabis, what we're talking about, there's actually a number of different plant species, but there are two primary ones that we're really looking at, sativa and indica. And they have different amounts of the different cannabinoid chemicals in them. And sativa is locally referred to as hemp. And a lot of these cannabinoid chemicals that the plants make are acting on an endogenous signaling system that is widespread throughout our body. So we have an endogenous target, and that's why these chemicals have effects in our body. And kind of the intracellular receptors that we have best characterized are called CB1 and CB2. And again, I'm not going to go into too much detail here, but CB1 is widespread in the nervous system. And particular parts of the nervous system have particularly high concentrations, like parts that are involved in appetite, parts that are involved in emotional regulation and memory have particularly high levels of CB1. CB2 is found more in the immune system, particularly with macrophages, other like dendritic presenting cells. And this widespread distribution is why cannabinoids have psychotropic effects, but also why they probably have anti-inflammatory effects, potentially even immunomodulatory effects, just because of the wide range of different places where these receptors live. And when we think about the active chemicals that are produced by these plants, you likely already know most of this, but we're kind of two main ones that we focus on. The first is tetrahydrocannabinol, THC. The other one is cannabidiol, which is CBD. And generally, and this isn't completely exclusive, but the THC is what causes the psychoactive effect, like the high that goes with cannabis, primarily driven by THC. It's also probably the one that is more responsible for the antiemetic parts and kind of the relief of nausea, and it has particular effects on the analgesic side. CBD, in contrast, and this is probably part of the reason why it is federally legal, does not do the psychoactive properties. It doesn't really have much of that effect. It has more of an anti-inflammatory effect. It's also the one that drives the anti-epileptic, antispasmodic effects that cannabis can have. And it probably has some effect for anxiolysis and different ways for analgesic, maybe through the anti-inflammatory part. Now, this is maybe going back to medical school, right, where we're having flashbacks to physiology. But this is just a look. I just want to show you where the different receptors live and kind of how the endogenous system that we have, that's the target, works. And one of the things that's really cool about the endogenous cannabinoid, the endocannabinoid system, it works in a retrograde fashion. So like we all learned that we have a presynaptic terminal, right, and a postsynaptic terminal on our axons. And right, the presynaptic one, there's a depolarization that triggers a release of neurotransmitters, which flood the cleft and go and trigger the postsynaptic neuron. The interesting thing about the endocannabinoid system, so the target for cannabis, is that it actually goes the other way. The receptors actually live on the postsynaptic side, and things like this anandamide trigger the release of, like the production and release of different chemicals that go the other way, and that actually lead to triggering or suppressing of the presynaptic neuron. So it signals the other way than usual, so retrograde. And which the different targets, so THC has a high affinity for CB1 and CB2, whereas CBD, which again has very different effects, curiously, it looks like it has intracellular effects that are very different. So it doesn't actually work primarily through the CB1, CB2, it's acting on the receiving or the postsynaptic side. And this is probably part of the reason why THC has such very different effects than CBD does. And both of them have relevance when we're thinking about treating human symptoms and conditions. Okay, hopefully not too many people see. So let's talk about what is available if we were to prescribe. So there are a couple of FDA-approved options, like synthesized purified compounds. Likely, I think everyone has probably seen this. So THC, there is dronabinol, which is essentially, it is a lab-produced THC molecule. And it exists under a couple different brand names. There was another more specific, kind of more efficacious one that has been pulled from the market because of really concerning side effects. And this is FDA approval for anorexia and nausea and vomiting secondary to like chemotherapy. And I'll talk about the evidence basis for this in a little bit. There's also a CBD, cannabidiol, at a higher concentration, even though you can just get CBD now at grocery stores, that was approved for childhood epilepsy syndromes. And I'm an internist, I don't do any pediatrics. I imagine there are a number of you here who do, who probably know more about some of the epilepsy syndromes where it has utility. But like some of the refractory childhood epilepsy syndromes, which are just awful. This is like one of your kind of last line resorts that can work. And then last, I'm going to make mention of a particular compound that is not approved for the United States, but I'm going to make mention of it. There's actually a mixture of CBD plus THC in a 1-to-1 ratio. whereas each of these are like specific. This is THC, this is only CBD. In Europe, there's this product called nabiximols, which has both in a 1-to-1 ratio. I'm calling attention to that because when we talk about all the trials and the data, a lot of it was done with this. And so where we see that there's evidence supporting treating conditions, they were using the compound that we can't get here. At least we can't prescribe. That's not FDA approved. So, all right. I'm gonna go ahead and keep going. So I've been talking about, I promised I'm gonna go over the evidence. So let's get to the evidence. So this busy slide, what I've highlighted are kind of the conditions that have the largest body of evidence. And the ones in green are probably overall the best quality of evidence. And I'm actually gonna focus on each of them in turn in a moment. Overall, a general theme that I will repeat when I talk about all this evidence is that the studies are small. There's a lot of methodological bias that was present in a lot of the different studies that we have. They have significant risk for bias, and ultimately, like, the quality is limited. And you'll see some of the sample sizes on these trials, and like, this is not Sprint, right? These are not our big hypertension trials. We have small numbers, and we have to try to extrapolate from what we have. The other thing I want to call attention to here, I was certainly taught in medical school that, like, for glaucoma, cannabis is one of those things where it might make sense. And the data is really just, we just don't have it. Like, there's not much. And I'm not an ophthalmologist, to be curious if there are any ophthalmologists here. When I went and looked, like, this is something that has been suggested for a long time without a lot of really support. So let's actually focus on the ones that have really more evidence, and I think are particularly relevant to us in primary care. So first is chronic pain. And what I've highlighted here are some of the different specific chronic pain syndromes that have been looked at in a number of the different RCTs that we have for this. And I've highlighted, so we have cancer, there's several different trials looking at neuropathic pain, including diabetic peripheral neuropathy pain, also pain related to multiple sclerosis, and then inflammatory arthropathies, just chronic pain syndromes, as well as fibromyalgia. And in a lot of the trials, they're either comparing to, well, they're primarily comparing to placebo. And I think this is particularly important when we think about analgesia and we talk about cannabinoids. For anyone who's ever taken cannabis, like, it has an effect, like there's a psychotropic effect, right? It causes that high. It's really hard to create a blinded trial, particularly when you're comparing to a placebo, when the active ingredient has a very recognized effect. It really makes it hard. And you always wonder, like, how much of the pain relief is that versus, you know, its actual impact on pain. And as far as the different cannabinoids that were looked at in these different trials, a number of which were done in Europe, a lot of them were done with this thing, this nabiximols, which is that 1-to-1 THC to CBD that we don't have available here. But there were trials looking at inhaled cannabis. Like, they would source their own cannabis and have patients smoke it. Which, as you can imagine, quality control and being sure what the dose there is really hard. And then some were looking at edibles, again, very hard to know and compare across different patients. And then a couple of them with the dronabinol, which is the THC that is FDA approved, as well as the other one, which is no longer on the market. Now, I'm going to show you a dense forest plot here. And really, this kind of the take-home point. This is an aggregate of looking a lot of the different, kind of the best, better methodological trials. And they were looking for a number of those different pain syndromes that I mentioned on the prior slide. And what we can see here, when you aggregate it, there's a slight favoring to a reduction in pain scores. Patients felt like they had less pain. No, good thing. The other things I want to call attention to here, like, these are our ends. And for those in the back, like, I mean, the highest end here is like 250, and most of the trials are a lot smaller. So, you know, not a lot. The other interesting thing, and you can see here, like, this trial where looks like it might have the strongest effect. This is with inhaled cannabis, like they were smoking cannabis. And in fact, generally speaking, higher doses led to a better improvement with pain. That was the trend that has been seen. However, the higher the dose, the more the side effects were limiting, like the sedation, the other properties that cannabis has. So you kind of have to walk a tightrope here. And so the side effects often were limiting there. Patients often reported that, yeah, they had less pain, but they were also asleep all day, or it was hard to get out of bed, things like that. So, and I think one of the interesting things, in particular, it was some of the pain syndromes that weren't cancer related. So they weren't metastatic cancers. It was like the neuropathic pain syndromes, where it looked like there was a greater benefit to the different cannabinoids to treat pain. Now, what this leads to me in my practice, and I'd be curious for all of your practices too, we see a lot of chronic opiate therapy, right in the middle of an opiate epidemic. And one of the questions, and certainly one of the things that proponents for cannabinoids argue, is that this will let us use fewer opiates. And fewer opiates is a good thing. I think everybody would generally agree with that. Now, this is survey data from California. So this is like patient self-reported data after California legalized cannabis. And these are just patients who were on chronic opiate therapy, and they were asked a couple of questions. And the blue colors are patient strongly agrees with the question, and kind of the red orange is they disagree to different levels. And so this first column here, did patients feel like they were able to decrease their opiate dose? And hopefully you can see the trend here. The vast majority felt they could take less opiates when they had cannabis. Again, this is all self-report data. I'm going to give you some different data in a moment that reinforces this. Other ones, this bar here, patients also felt like when they were asked, do they feel like they can tolerate the cannabis side effects better? They did. They overwhelmingly felt the cannabis side effects were better than the opiate side effects. Also, I think encouraging. The next question, which we see the blue bar is not as overwhelming, is they were asked, is cannabis more effective for your pain than the opiates? Still, the majority thought that it was. Again, this is all patient self-report, but it is interesting. This next set of slides, which I will walk through, is actually trying to look at, well, in states that legalized cannabis, did opiate prescribing go down? Did opiate use go down? So we have three bars here. The first is Colorado. The other two are like the controls, Utah and Maryland. And the three different graphs represent different things that the authors of the trial, of the study, were looking at. So in the first graph, the first bar in each of these, the black, is opiate prescribing before Colorado legalized cannabis in 2012. So they were looking at Colorado, where they legalized, and Utah and Maryland, which at that time was not legal. And then the white bar is what happened to opiate prescribing, like how many opiate prescriptions were filled and the amount of MEDs after legalization. And what you can see, and right, the star indicates this, in Colorado, there was a statistically significant reduction. It was a fairly significant and pretty good reduction in opiate prescribing and like actual opiate prescriptions filled. Utah, there was no change, which, right, why would Utah, it wouldn't change. Colorado legalized, what would they do to Utah? And curiously here, and I think this is a very clever way that the study authors looked at it. They looked at Maryland. Maryland did have a drop. Maryland didn't legalize, but Maryland had a reduction in opiate prescribing during this interval too. And again, I think this was really clever the way they looked at it, because this leads to the next slide. Maryland kind of launched an initiative to really aggressively tackle opiate overdoses, right? Because this is when opiate epidemic we're starting to recognize. And so this is basically a graph. It's a surrogate for looking at treatment of opiate use disorder. And they're tracking buprenorphine and methadone prescriptions here. And during this interval, where Colorado legalized cannabis and Colorado saw a reduction in opiate prescribing, as did Maryland, Maryland saw a big increase in prescribing bupe and methadone. So like in this case, we have a pretty good explanation for why Maryland's opiate prescribing went down overall. And of course, Utah, there was no change because again, Utah didn't do anything here. And while Colorado had an increase, it was a pretty small increase. So Colorado was also working on opiate use disorder, but really their big intervention was legalizing cannabis. And so this is kind of put together in this last slide where they're simply tracking basically your morphine dosing equivalents per person that was prescribed. And what we see here, the two graphs that are dropping, this is Maryland and Colorado. And we're seeing here the prescribing of Maryland of bupe and methadone going up. So basically, when trying to control for differences between states, legalizing cannabis in Colorado led to a reduction in opiate prescribing. That's kind of the take home here. And it does match with that data I showed you on the prior slide with California residents feeling they could use less opiates if they had cannabis. So I'll pause there. Any questions? If not, we will continue. So I'm going to move on to the next indication or the next condition that's been fairly well studied. So nausea and vomiting, particularly secondary to chemotherapy. This is another one where we have that FDA-approved THC, dronabinol, which is approved for treatment of chemotherapy-induced nausea and vomiting. And that data is actually pretty dated now. It comes from like 20 plus years ago. But they were looking at THC as well as different cannabinoids, but particularly THC, and comparing it to like prochlorperazine, metoclopramide, so kind of our other main antiemetics at the time. And here the data is pretty good. I'm not actually going to show you bar graphs and everything, but basically THC was comparable to superior to those other antiemetics to treat chemotherapy-induced nausea. Like patients felt they had better symptom relief, better control. And they also had more side effects with the cannabis, but they tended to prefer it. And I think as we have been taught and we've learned, well, a fair amount of the emesis that goes with chemotherapy is partly anticipatory. The anxiety of it all partly drives that. And this may be where THC's anxiolytic properties are helpful, like calms patients down, as well as has its antiemetic effects, both of which synergistically lead to an improvement. Really, the only critique I would make here, this was done during an era where we didn't have the newer antiemetic regimens we have for chemo that we have now. And if we have oncologists in the room, they could probably speak better to it. But basically, right now, if you're treating patients with different types of chemotherapy, these probably are not your first-line antiemetics. And we don't have newer trials comparing to other options like steroids and other things that we use now. But overall, much better footing of evidence that we have. The next is spasticity, and this is also an area where we have pretty good evidence to support. Primarily looking at multiple sclerosis as well as paraplegia-induced spasticity conditions. And there was an improvement both in patients, like their sense of their spasticity, as well as like physical exam findings. So that's pretty good as far as improvement. And just putting the forest plot together here, you can see this is favoring the use of cannabinoids, and particularly CBD is your helpful agent here. So this is another condition where we have pretty good evidence to support. Next is anorexia, particularly in the setting, the two that we looked at are cancer-induced and HIV/AIDS-induced. I think we've all seen treating anorexia in these situations is really hard. We generally can't move the trajectory of the condition by trying to get people to eat more, and it's probably a complication of their treatment and just the illnesses themselves. However, both dronabinol, which is just that purified THC, as well as cannabis, was studied in both of these and compared to placebo as well as to the progesterone megestrol acetate, MEGACE. And overall, it was pretty mixed. Probably superior to placebo in terms of weight gain, appetite, body fat, particularly with HIV/AIDS. And it had a comparable effect to the progesterone. So they were kind of equal, they were non-inferior. And overall reduced benefit in cancer, like ultimately not trying to be statistically significant. But really what we found is ultimately a gain in weight and appetite, but not necessarily changing the trajectory of the illness, of course. So I'm going to now transition a little bit to the adverse effects. I'm going to come back to a summary once I've gone through all of this to kind of say, where does that put us? But when we think about the adverse effects, there are a lot. And when I'd asked who had treated complications of cannabis, like everybody's hand went up. So just as a reminder, like just the acute effects of cannabinoids, there are a lot of different ones, but particularly the neurologic and the behavioral, right? It's sedating, it can cause the high, which particularly for people who are not used to it can actually be anxiety provoking. It has all those anticholinergic effects, right? The dry mouth, the red eyes, does all of that. And gastrointestinal, and this one I'm going to come back to when I talk about the hyperemesis syndrome in a minute. But rather than talk about like kind of what people experience when they take cannabis, I want to talk about kind of the complications of chronic use, because one of the themes of my talk here is harm reduction and giving guidance to our patients. And there are trade-offs with long-term cannabis use. I don't think that's news to anyone. The gastrointestinal, like I said, I'm going to come to that on a particular slide in a moment. But some of the others. So it turns out probably smoking anything is not good for our lungs, just isn't. In cannabis in particular, when inhaled, there's a condition that can predispose you to an invasive aspergillus infection, which is awful, but also probably increases your risk of reactive airway disease and obstructive lung disease. Like acutely, when you are smoking cannabis, you see the same effects you do with nicotine as far as like cardiovascular dynamics. You can see an increase in blood pressure and heart rate that goes along just like you do when you smoke tobacco. The cognitive ones I think are particularly important, particularly for those of us who are working with kids or with young adults. This is like colloquially known about pretty well, right? The image of a stoner. But what we know, we have kind of increasing evidence to suggest regular cannabis use, yes, it probably impacts your performance in school. It might lower your IQ and other cognitive processes. not just while you're using, but potentially even downstream of that, like years ahead. And that's pretty scary, right? When brains are developing and growing. Yes. Probably more at the THC and the cannabis. But that said, generally in this age range when it's being used, it's cannabis, like it's from the plant, so it contains both. And then the other, which is also probably mediated by THC, but hard to say that with certainty, is psychosis. I have another slide on this in a moment, but basically it predisposes people who are already vulnerable to having like psychotic episodes. Then the dependency and withdrawal. So definitely you can have physiologic withdrawal from regular use of cannabis. And the dependency risk is probably, and it depends on the study you look at, but somewhere in the range of like 5 to 11% with regular use. And that's different for adolescents versus adults. But nonetheless, it's definitely there. And obviously no one's ever going to do the trial looking at is this safe during pregnancy. But there's enough to suggest it probably, at least we should be very cautious and strongly recommend to our patients to be very careful. Like we know in Washington, there has been an increased use during pregnancy because it's recreational, it's available everywhere. And so I think we have enough to say that it probably is increasing fetal risk. And then others, and I think this is particularly important, and when I say this to my young male patients, it gets them to sit up. But it does look like it might impact fertility, both for men and for women. For men, you can see like reduced sperm and semen. And there may be, and this is very questionable, like an increased risk for testicular cancer. So if you have that adolescent who you're working with and you're trying to convince them or try to build a case for them not to use cannabis, that might be a good one to lean on. So those are just some of the things that we need to be able to guide and kind of inform our patients of. Now thinking about some of those in kind of more focus. So the risk for psychosis. And this is a pretty strong hazard ratio. Basically, regular cannabis use several times a week to daily has a pretty dramatic increase on your risk of a psychotic disorder, including schizophrenia. And what do we do with that? Does that mean if you use cannabis regularly, you will develop schizophrenia? No, of course not. However, it increases your risk. So if you're already someone with an elevated baseline risk, that's an important detail. So my patients who have a strong family history of bipolar disorder or other psychotic disorders, schizophrenia, schizoaffective disorder, really make a point of bringing this up. Like you are increasing your risk of something that nobody wants. The next thing I talk about is the withdrawal and dependency. So as I was mentioning, it's hard to know exactly what the risk is of dependency on cannabis, but it's definitely there. And treating it is challenging, as it is with any substance use disorder. Generally, and that's because a lot of the treatment has been studied in adolescents, looking at family-based therapy and CBT, cognitive behavioral therapy. And there's also some encouraging evidence with the use of N-acetylcysteine, which, right, this is a medication that gets trotted out, it seems like every couple of years for a new condition, liver, like neuroprotective effects. But it looks like it might be helpful here because of some of its effects on the brain to help. So. And then kind of thinking about the withdrawal symptoms. Now, particularly in Washington, where the use is fairly high, but we know nationally, right, a lot of people are using cannabis. When we're taking care of them in the hospital, right, they are going to go through withdrawal. And the symptoms of withdrawal are things like irritability, anger, and aggression. Now, if I was trapped in the hospital recovering from something, I probably am not going to be in a good mood. I understand that our patients aren't either. But it is worth thinking about if you have a patient who's demonstrating a lot of irritability, kind of discomfort with staff, and they've been in the hospital for like 3 to 4 days. You ask everyone when we admit them about alcohol use, because we're thinking CUA, we're thinking seizures, DTs, which are horrifying. But also worth maybe asking about cannabis use too, because you might want to treat them for that. And acutely, kind of the way to treat anxiety and insomnia, the irritability, benzodiazepines have a role here. Like that's the inpatient setting, that's reasonable. You can also use gabapentin for some of the other things like particularly the insomnia and some of the like the sweating, the chills, some of the adrenergic effects. And I think an important point, I didn't mention some of the other pharmacology, the cannabinoids, but there are some interactions with different serotonin receptors in the brain. And curiously, SSRIs can actually potentiate the anxiety. So if you have an anxious patient in the hospital, like, I'm going to do the outpatient PCP a favor, I'm going to initiate this SSRI, maybe not a good idea. That might not actually help in the short term. It might think things a little bit worse. They might find that their anxiety goes up. So the next one, and I put this slide in because I've been asked this question before, like, does using cannabis, does that lead to other drugs? Does that lead to other illicit substances? And that's a really hard question to answer because that's not something we're ever going to get a firm body of evidence to say, yes, we use this, we will get that. This is looking at, this is a retrospective analysis, like basically just patient questions, asking for those who had used cannabis regularly and thinking back to when they first started using cannabis, if they ever used other illicit substances, did they use cannabis first? Right, that's maybe not the greatest survey question. However, what we found was, up to 40% of people who used other illicit substances had first used cannabis. Now, does that mean they were going to likely end up using those other illicit substances otherwise because of other socioeconomic reasons, other stresses in life, or was it tied to the cannabis? Hard to say. But I mean, from what we have, using cannabis at a young age maybe predisposes. Again, I wouldn't be comfortable saying anything stronger than that. Okay, next, the cannabis hyperemesis syndrome. So this is something we're seeing increasing amounts of, and we're seeing it probably in part because a lot of states are legalizing cannabis use. The incidence is unclear, but generally it is associated with regular cannabis use. The more frequent, probably the higher the risk. And for those who've seen it, right, it has some really unique features, but these are repetitive, cyclic, like nausea and vomiting episodes, usually with abdominal pain. And these people are just miserable. They just cannot stop throwing up. They are just absolutely miserable from it. And antiemetics are marginally effective. And really the interesting thing about this that kind of calls out, you should be thinking cannabis hyperemesis, is you ask, when you get these at home, do you ever crave a hot shower or a hot bath? And people will tell you they will spend hours in the shower, like just hours with the water turned up until they run their water heater empty. And that's probably in part, and I didn't mention this either when I was talking about the pharmacokinetics, but one of the things that CBD acts on is the same receptor that capsaicin does. Capsaicin is the spice that causes that hot sensation. And so it may be something to that mechanism. When they're taking the hot showers, they're triggering that receptor. And that leads to something about capsaicin, which I'll talk about in a moment. The other piece that makes this kind of hard to diagnose, patients will tell you, well, I didn't use cannabis in like 2 weeks. I decided to quit. And here I am throwing up 2 weeks later. And that's because one of the other really interesting properties of the cannabinoids, they are incredibly lipophilic. And I'll talk about that when people are taking edibles, it's important. But the part about this that matters, those who have more adipose tissue will build up a depot store of it. Basically, they will get a slow release of their cannabis if they've been using it regularly. And that can go on for months. It's also relevant if they are wondering about being drug tested for work. If they could have used cannabis weeks ago, it can still show up in the urine. It can show up for quite a while afterwards. And so this sometimes makes it hard for us to get buy-in with them to convince them that the cannabis is the problem here because it isn't temporally related or it doesn't seem that way to them. Now this part, this is just looking at who gets cannabis hyperemesis. And again, we don't know how often it occurs with regular use, but looking at patients who are diagnosed with cannabis hyperemesis, the majority were using it at least daily, if not multiple times a day. So higher use looks like it increases your risk. Now, in terms of how does it happen? Because on one hand, we use cannabis, and I just told you there's data to show it helps with nausea and vomiting. Why is it causing severe episodes of nausea and vomiting? And this is probably because there are multiple different effects of THC on the brain. It definitely goes to some of the centers that are responsible for nausea, and it helps kind of mitigate and suppress those, which helps with its antiemetic effects. But you probably develop some degree of tolerance to that effect with regular use. The other thing I mentioned earlier, that receptor, CB1, is present throughout the body, including all of our nervous system, including that in the gut. And so one of the other properties of THC, probably more so than CBD, is that it's gastroparetic. It slows down gastric emptying. Now, for people who are using it sporadically, not using it often, the antiemetic effect in the brain of the THC probably overcomes any mild gastroparetic effect. But with regular use, you lose this effect on the brain, you really boost the gastroparetic effect on the stomach, and you get this something that looks like gastroparesis. They can't stop throwing up. And of course, as you would expect, the treatment is abstinence, and they have to go months. And it's because of that depot effect, that lipophilic nature. So we really have to convince them to get buy-in, because that's hard to do. In the moment, if you're taking care of them in your urgent care and you're seeing them in clinic and they're just miserable, what can you do? So I mentioned, and this is something that there have been some exciting case reports, capsaicin. So you literally get capsaicin cream. We also can use it for diabetic peripheral neuropathy, and you have them rub it on their stomach. That's pretty benign. It will just make the skin feel really warm, as long as they don't put it in their eyes. And it hopefully is triggering that receptor, the same thing that this cannabidiol is doing. But it looks like it gives them some relief with the discomfort and the vomiting. The other option, right, is significantly more powerful, but there are actually quite a few case reports looking at haloperidol. So when you have a patient who's just miserable in your emergency room, this might be more efficacious than your antiemetic cocktail to give them a dose of IV haloperidol, which of course there's all sorts of things that go into that, which I won't talk about. So that's cannabis hyperemesis syndrome, really challenging, increasingly frequent. Think about capsaicin. Okay, so now I want to transition into counseling our patients and harm reduction. So first things, these are firm contraindications. So this is worth part of our preventative care visits when we're assessing for smoking, alcohol, and we ask about illicit substances and other chemicals and other supplements that people are taking, really to remind your brain is still developing by the time in your early 20s. And so for that risk for those cognitive changes, those long-term changes, really avoid before the age of 25. And that's hard because we know adolescents are a group that cannabis use is pretty prevalent in, but they may be risking their brain health down the road. Avoiding pregnancy, then really stressing this, avoiding with the family history of schizophrenia, schizoaffective disorder, bipolar disorder, any condition where they might be predisposed to psychosis. And then of course, some of these others go without saying, avoid in a history of substance use and dependency. And caution with cardiopulmonary disease. Our patients who have heart and lung problems shouldn't smoke. Now, I'm going to come back to this in a little bit, but certain drugs, THC is an inhibitor of one of the cytochrome P450 enzymatic pathways, particularly 2C9. And if you have other medications that either go through that pathway and are metabolized or themselves are inhibitors, you can get pretty powerful synergistic effects of boosting levels, which you probably don't want. So there's some particular drug categories we got to be really careful with. And then finally, do not drive after use. I spent a lot of time looking to kind of find what is our evidence to say how much this impacts driving. And again, that's always evidence that's hard to get. It probably does slow down reaction times a little bit. It might not impact decision-making as much as say alcohol, but probably does affect reaction times. There's some trials from Oceania, it's either New Zealand or Australia, where they were able to document that indeed reaction times were slower. What's really, I think, interesting, if you mix alcohol with cannabis, you kind of get the worst of both worlds as far as safety for driving. Because you have the lowered inhibitions and the slower reflexes, so you can't compensate at all. So it does look like truly using both together is synergistically and multiplicatively more dangerous than using either alone when it comes to driving. Okay, I'm going to go back a little bit to the pharmacokinetics, but really in the context of how do we advise our patients. So the first thing that I think it's helpful to know is the bioavailability of different methods of taking cannabinoids. Unfortunately, inhalation probably gets the most reliable, predictable effect. And that's because there is a huge first pass effect through the liver for the cannabinoids. 95% of them are just inactivated. And so when you absorb through your pulmonary capillary beds, you get really rapid onset and you get a predictable effect because it's not being inactivated by going through the liver first. You get a high bioavailability of 25%. In contrast to those that we take orally, either sublingually or swallowed, like edibles. Now, the lowest bioavailability is through the orals, and that is because, again, they get absorbed in the digestive tract, they go to the liver, they get inactivated. So you get a very low amount of it bioavailable. And it's very hard to predictably dose because of that, because you can get very little coming in. And in fact, a lot of overdoses come from edibles, in spite of the slower bioavailability, because someone takes an edible, they feel fine. They take another, they still feel fine. And it's because it's still digesting, it's starting to absorb, and at some point it's going to start to catch up with them. The other thing, the fat content of the meals has a huge effect. Remember that lipophilic nature of cannabinoids? So if you have a fatty meal, you have a whole bunch of chips and with dip, or you have a pizza or a hamburger, that's going to help you absorb that cannabis. So let's say they get the munchies after they've taken a couple of brownies. Well, they're all of a sudden ripe to get a huge increase in the THC and CBD and other chemicals in their blood. So that's helpful to give our patients guidance if they ask us. Like, what's the safest way? Well, edibles are probably safer because we're not doing any damage to our lungs, but you have to be really cautious. Now, probably the best of both worlds here is sublingual. You can get different oils and extracts that just dissolve under the tongue and absorb under the tongue. You get a higher bioavailability than orals, and it kicks in quicker. So it's quicker for them to see it. So if you have a cancer patient and you're trying to help them work through the nausea, they might get an oil extract, put a drop under their tongue, and you coach them. You're going to need to wait about 45 minutes to an hour, and that'll give you a good idea of how strong that one drop was. If they're smoking, you'd have them take one puff, wait about 30 minutes, they'll know its effect. If they're going to try it by the edible, they've really got to wait like 1 to 2 hours to know what that did. So that's just bioavailability, thinking about the pharmacokinetics of it. It has a really long half-life, very lipophilic, that matters for that cannabis hyperemesis syndrome. And the metabolites, as I mentioned earlier, can persist for weeks. And then that P450 that I mentioned and 2C9, some of our favorite drugs get metabolized to those pathways. So some of your antifungal drugs, as well as benzodiazepines, and then some chemotherapy agents and antiretroviral agents, which is relevant because right, these are categories where we literally might be prescribing the FDA-approved THC compound. So this is where your clinical pharmacist can be very helpful. Right. So where does that put us in our guidance for our patients? When I have patients who ask me, one of the things that I emphasize is that we don't have a lot of evidence here, but these are the conditions there might be some benefit. So like certain chronic pain syndromes, spasticity, and thinking about nausea and vomiting, and maybe anorexia. Start low, go slow, and ideally try to get a 1-to-1 ratio of THC to CBD. I didn't talk a lot about the commercial formulations. I'd be happy to do afterwards if people are curious. But basically, you go to a dispensary in Washington and you can get a whole range of different ratios of THC to CBD, basically different concentrations of THC. And if you're looking to help them with nausea, you might want to suggest a higher ratio of THC to CBD. And if you're looking to avoid the psychotropic effects, use more CBD, right? The THC is what causes psychotropic effects. Smoking or inhaling it, more predictable. Sublingual, also more predictable and easier to titrate the dose. And this is one of the cases where I would suggest to consider. One of the interesting things about Washington, the state law requires if you're going to open a dispensary, you have to have one staff member who's had at least 20 hours of training on cannabis. What that training is and what it involves, there's a fair amount of variability, but odds are their 20 hours might be more experienced than we have in terms of guiding people on what to pick. So generally we don't say, well, go ask your uncle to figure out what dose of, antibiotic you should take. But here you might be able to say, go to the dispensary, ask them to talk to their person who's trained, because they have someone on staff who's had 20 hours of training. That person might be able to give them more guidance on like which products should they choose, because there's a plethora of products. All right, so I'm going to go back to our clinical scenarios, and we're finishing it here. So that 55-year-old with a painful diabetic neuropathy whose daughter suggested that they try CBD. So what do I think? I think it's reasonable to try. First of all, CBD, very legal, they can get it anywhere. And it's likely safe. Again, it's the CBD side of it. I'm not worried about any of their medications interacting with it. It's not going to cause a lot of psychotropic effects. It may have some anti-inflammatory properties, maybe reasonable. And I'm going to suggest the sublingual absorption would be the way to go. I prefer my 55-year-old with diabetes not take up smoking. But that would be what I would suggest. And I think here we could say that's reasonable. It might help with your diabetic neuropathy. It has been studied for it. Now for a 75-year-old with severe degenerative joint disease who's on chronic opiate therapy, asking about can they start smoking marijuana? And is it safe and will it help? And I think here, on one hand, they have severe degenerative joint disease, right? That's very painful. If you recall back to when I showed you the different conditions that have been studied, osteoarthritis is not one where we have a good RCT on. So, less clear if it would help here, but it helps with other chronic pain syndromes. Well, maybe. Smoking carries risks. Maybe suggest trying an extract instead. And then, will I prescribe it? Well, even though I'm in Washington, no, we don't prescribe it. Again, there might be a role for me providing them with a medical attestation, because that will save them sales tax, but otherwise we don't prescribe it, of course. And this would not be something where I would be thinking about prescribing the FDA-approved THC dronabinol, right? Because that's approved really for nausea, vomiting, anorexia, not specifically for chronic pain. So, all right. So in summary, kind of the take-home points. Cannabinoids, there are a whole bunch of different chemicals, but the main ones we know about are THC and CBD. They have different properties. And I think there's potentially a role here for chronic pain, chemotherapy-induced nausea and vomiting, spasticity, anorexia. And it's contraindicated. Really remember that psychosis, pregnancy, young adults, right? We don't want to risk their brain, and of course, substance dependency. It's easier to titrate the sublingual and the inhaled forms, but if you're going to suggest, tell them, look for a 1-to-1 mixture of THC with CBD. And then, of course, as always, titrate to the lowest dose that gives them relief, right? We never need to go higher than that. All right. I think we need to go to questions, so I'm going to stop here. And I'm happy to talk about synthetic cannabinoids for anyone interested afterwards. So. Yes. Yeah. So someone who, great question, you were asking about SSRIs and the anxiety component. So it's really just in reference to people who are withdrawing acutely from regular cannabis use. I wouldn't reach to an SSRI to treat that acute anxiety. You might potentiate it. For people who are suffering from long-term anxiety, SSRIs are still very reasonable, and you might still be counseling them about reducing cannabis use. Should I just call it out in blue?
I have a lot of patients with ADHD in my practice, and I feel like I'm going to make this statistic up, but it feels like 60% of them tell me that it's the best thing or the only thing to help them sleep at night. And smoking it works. The CBD that's legal in Idaho doesn't. Seems to be like a very common refrain. And I'm curious, do you know anything about why or what might help them instead without me having to have my 20-something-year-olds smoking marijuana every night at bedtime with their stimulants?
With their stimulants.
So
it's a great question. And I will say anecdotally, I've also had that experience with patients. So to the question about for sleep, and I as I mentioned, cannabis has been looked at as far as benefits for insomnia, and the effect was very small and different in different trials, to the point that we can't conclude that there's any benefit for people with regular insomnia. So I wouldn't suggest using cannabis for sleep. Like, we just don't have a firm footing to say that, which is kind of a broader question than the question you're asking. In the setting of like ADHD, that's a really hard one. I would go back to like CBT for insomnia and really looking at like sleep behaviors and trying to kind of counteract and think, can we adjust if they're on stimulants? What can we do with that? And then really hammer home this could be changing your cognition long-term. And we can be fairly confident that cannabinoids do not improve concentration. They don't improve work performance generally. So they're not helping themselves probably. And they might actually need less stimulants if they're off. And I know that that's right, the case that you make, and it's a hard one. I wish I had something better to say than that, but yes.
Since there's no breathalyzer for marijuana or THC, how do the police determine the areas in driving?
That's a good question, and I don't think I could give an exhaustive answer on it. My understanding, right, it's partly based on, right, if you're clearly looking like you were impaired while driving, and that can lead to them requesting a test, which is usually either going to be urine or potentially a hair sample, less likely blood. But I think that's where they would get to be able to document that it's there. Or in the case if someone ends up in an accident and ends up in the emergency room and gets tested there. Although I don't know how that works in terms of court. Because you're right, there is not a test that they can do in the moment, as far as I know, that would show that.
I worked for a few years in Colorado a few years ago, and a lot of the ortho guys would talk about pain control and obviously a lot of marijuana use. And generally what they kind of talk about is that it should be opioid for marijuana, but using them together, they would kind of counteract each other. Have there been much studies about that?
Great question. So about cannabinoids plus opiates. So in the chronic pain, a lot of the studies, like a fair number of them had patients who were already on chronic opiates. So I think generally speaking, my advice to my patients is, if we're thinking about where you need to treat your chronic pain, if we're looking at cannabis as a way to help control your pain and reduce your opiates, that's a win-win. Is there any reason to say we can't use them both at once? No, although they both have sedating properties on the brain, and more sedation is probably not better. So I'm kind of giving you a wishy-washy answer here because we don't have a good, other than to say that some of the trials that the people were really on opiates and they felt like they could use less opiates with it potentially. So I would generally agree with that sentiment. I'd say if you're going to use cannabis for treat the chronic pain, then let's not start the opiate pathway. And if you've already found cannabis works, you know, I think I can safely say for most people it's probably safer than long-term opiate use. That would be confidently say. So I know there are a lot of hands.
All right, we're out of time for this talk, so we're gonna, Dr. Shenoy will probably have some
Yes.
time for some questions if you guys want to snag him later.
I'll be over there.
Excellent talk. We do appreciate it. Thank you.